Good morning, good afternoon, and good evening, philosophers. Welcome to episode 16, the final episode in this series of Philosophy of Science through the lens of medicine. Last time, we concluded that medicine is not uniquely Western. Humans treated wounds, used medicinal plants, and theorized about disease long before anyone invented a lab coat, a prescription pad, or a 6-month waiting list. But one medical tradition, what Alex Broadbent calls mainstream medicine, has become globally dominant. So today we ask the final question: is medicine colonized? And if it is, what would decolonizing it involve? Calling medicine colonized doesn't mean that every stethoscope is secretly working for the British Empire. It points to several connected injustices. First, medicine was sometimes part of the machinery of colonial power. Sarah Bartman, the enslaved woman operated on by J. Marion Sims, and the men deceived in the Tuskegee syphilis study show how racialized people could become research material rather than their moral equals. Second, colonialism shaped the distribution of health. Populations stripped of land, wealth, and political power were left with worse living conditions and poorer access to care. Those inequalities didn't politely disappear when the flags changed. Research funding in prestigious institutions remain concentrated in wealthy countries, while many formerly colonized populations receive under-resourced services and imported policies. Third, there's epistemic injustice. Injustice against people as knowers. Whose symptoms are believed, whose concepts are understood, whose remedies are investigated, and who receives the credit. Indigenous knowledge has often been dismissed as superstition, then extracted and sold once a laboratory finds something profitable. Apparently, a plant becomes knowledge only after a pharmaceutical company puts it in a box. Broadbent considers 3 ways medicine might be decolonized. The first is decolonization as fairness. Give everyone access to effective mainstream medicine. Desirable, but access to whose medicine? If an elite still decides what everybody needs, universal provision can preserve the old power relation beneath a more generous surface. The second is decolonization as epistemic equality. Treat rival traditions as equally authoritative. This sounds respectful, but threatens wholesale relativism. If antibiotics and an ancestral ritual make contradictory claims about tuberculosis, they can't both be correct merely because both belong to different cultures. Illness has consequences outside the seminar room. Broadbent therefore favors critical decolonization grounded in medical cosmopolitanism. It combines 4 commitments. There are real medical facts. We should be humble about knowing them. Everyone has equal moral worth. And practical agreement should precede metaphysical combat. Indigenous claims must face criticism, but so must the mainstream canon. Nobody gets a free pass, not the doctor, not the healer, and rather alarmingly, not even the professor. Chad Harris agrees with this middle path, but thinks epistemic humility isn't enough. He tells us we may be wrong, but not how to judge rival standards of evidence. If a healer cites a revelatory dream and a physician cites a clinical trial, let us all be humble hasn't settled the disagreement. Harris therefore refines cosmopolitanism using Sandra Harding's strong objectivity. Objectivity isn't a magical view from nowhere. Researchers choose which problems and outcomes matter, who enters a trial, and whose testimony counts. Science must scrutinize its own values and blind spots and begin inquiry from marginalized lives. That changes practice. Traditional healers may see patients the formal system never sees. Involving them in referrals or disease surveillance can improve public health. Likewise, a lockdown sensible from a suburban home with Wi-Fi and savings may be brutal for a family living hand-to-mouth in a crowded settlement. Starting from the perspective of the marginalized is not charity, it's better inquiry. There is, however, a problem. Harris recounts a missionary who can't persuade a community to boil water by discussing microbes, but succeeds by saying the bubbles are harmful spirits escaping. 1 fact, 2 explanatory languages. Yet boil the water still came from Western medicine. The local worldview merely sold it, perhaps through deception. Medical cosmopolitanism may remain cosmopolitan in theory, but Western at the checkout. If standard Western evidential rules must decide which interventions enter the store, almost everything on the shelf will still be Western. The usual hierarchy gives enormous weight to randomized controlled trials. RCTs are tremendously useful, but the standard double-blind model fits pills much better than complex, personalized, or spiritual practices. Detach some interventions from healer, ritual, and cultural setting, and you've created a different intervention. Reducing the RCT's monopoly doesn't mean replacing evidence with vibes. We can use observational comparison, careful follow-up, patient-reported outcomes, changes in physical and mental capacities, qualitative evidence, and cost-effectiveness. If a traditional practice repeatedly leaves patients safer and healthier, that is evidence, even if nobody manufactured a convincing placebo sangoma. Mental health is especially promising. A rural African patient may understand distress through family, community, spirituality, or ancestors. A Western-trained counselor lacking those concepts may misread the patient before treatment begins. Someone sharing the patient's language and cultural world may build more trust and offer advice that fits the life being lived. Locally adapted, community-delivered talking therapies in rural Uganda, separately in Zimbabwe, have produced impressive results. That doesn't prove every traditional healer is an effective therapist, but it gives us reason to test culturally congruent counseling rather than dismiss it in advance. Now, the large warning label. Decolonizing medicine mustn't romanticize everything called traditional. The appalling myth that sex with a virgin can cure HIV has been promoted by some healers, and it's been linked to sexual violence and it risks spreading infection. Cultural heritage does not turn abuse into healthcare. But mainstream medicine has no spotless moral pedestal. It gave us thalidomide for morning sickness, destructive lobotomies, and ineffective treatments backed by authority and excellent stationery. We shouldn't throw the baby out with the bathwater, whether labeled traditional or scientific. This leaves the course's final question. Is decolonization fair access, epistemic redress, critical scrutiny, or all three? What counts as evidence when an RCT is inappropriate? If a traditional intervention is safe, effective, and cost-effective, is there any defensible reason to marginalize it? How much uncertainty should society tolerate while finding out? Most importantly, should medicine be decolonized? And if so, who gets to decide when the job is done? That brings us to the end of the series. If these 16 episodes have taught us anything, it's that every simple question about medicine contains at least 3 philosophical traps and 1 committee meeting. Please like and subscribe, and I'll see you on the next course.